Assalamu alaikum. Welcome to the second part of obstetric case taking, which is the common problems, differential diagnosis of common problems in obstetric case taking, and how to think with the underlying cause of any complaint. We start to the problem of the uterus larger than the period of amenorrhea. What are the underlying causes of the uterus larger than the period of amenorrhea? These underlying cause or differential diagnosis include miscalculation, multifetal gestation, fetal macrosomia, whether generalized or localized fetal macrosomia, such as fetus of diabetic mother, generalized macrosomia, a fetus with a grand multipara, a fetus with a large-sized mother, or other local fetal macrosomias such as fetal ascites, hydrocephalus, fetal abdominal or back tumors, and so on. The fourth cause of the uterus larger than the period of amenorrhea is the increased amount of amniotic fluid, such as polyhydramnios. Hydathiform mole, about 50% of cases of hydathiform mole present with larger uterus larger than the period of amenorrhea. Uterine tumors with pregnancy, such as the commonest, which is the fibroid. Concealed accidental hemorrhage is another cause for a uterus larger than the period of amenorrhea because of the amount of blood and the the port-like uterus. To the other side, the uterus smaller than the period of amenorrhea may result from miscalculation, small for gestational age, intrauterine fetal death, oligohydramnios, and incomplete hydathiform mole. The second complaint, which is bleeding early in pregnancy, the differential diagnosis of such case may include abortion with its different clinical types I will discuss in this next slide. Ectopic pregnancy, molar pregnancy, local gynecologic cause such as infection, tumor, or trauma, and general cause of bleeding, abnormal coagulation profiles, and platelet dysfunction may cause bleeding in early pregnancy. We come to the number one explanation of number one, which is abortion. What are the clinical types of abortion? The clinical types of abortion may include threatened abortion. In such a case, the bleeding is minimal to moderate. There is no discharge. The period of amenorrhea is equivalent to that of the size of the uterus. The cervix, when digitally palpated, is closed with no fever and no sepsemia. Inevitable abortion with the largest amount of bleeding in between these clinical types of abortion and the uterus is less than the period of amenorrhea and the cervix is opened, and this is the most diagnostic feature. Incomplete abortion, moderate bleeding, period less than the period of size is less than the period of amenorrhea, and the cervix is opened. Complete abortion, minimal bleeding, and with discharge period the uterus is smaller than the period of amenorrhea and cervix is a closing. Missed abortion, brownish discharge with no evidence of any franky blood, and the uterus is less than the period of amenorrhea with closed cervix. infected, any type of the above mentioned types, with pus extruding through the cervix, and with fever, septic abortion with septicemia. What are the differential diagnosis of first trimester bleeding? The item, this table will summarize how to diagnose the first trimester bleeding. Clinically, it may be abortion, ectopic, or molar pregnancy. In abortion, pregnancy is diagnosed. There is bleeding and pain. Ectopic pregnancy, short or no period of amenorrhea with bleeding, pain, plus or minus syncopal attacks. Molar pregnancy, diagnosed pregnancy, bleeding with bronchus appearance, plus or minus passage of vesicles, which is not common. With ultrasound, in abortion, intrauterine fetus, or remnant of conception. In ectopic pregnancy, empty uterus with or without adnexal mass, which is chain sac, with free fluid in the Douglas pouch. With molar pregnancy, there is no fetus in complete mole, or maybe fetus with partial mole. Partial mole, in most cases, is diagnosed as missed abortion. Snow storm appearance, incomplete mole. Beta HCG, appropriate to the gestational age. Ectopic pregnancy, no doubling within 24 hours, and molar pregnancy, markedly increased levels of beta HCG. Bleeding in late pregnancy or third trimester bleeding may be due to placenta previa, placental abruption, vasa previa, rupture of uterus during pregnancy, and previous myomectomies, previous resections, or with trauma to the pregnant uterus, such as motor car accidents or falling from a height, local gynecologic cause, infection, tumor, or trauma, and general cause of bleeding. These are all may cause bleeding in the last trimester or third trimester bleeding. Acute abdominal pain in early pregnancy may be due to abortion, ectopic pregnancy, appendicitis, complicated ovarian cyst as torsion of the cyst, hemorrhage into the cyst or rupture ovarian cyst, cystitis. Severe cystitis may cause suprapubic pain. Acute pyelonephritis may cause acute loin pain that radiate to the pubic area, and peritonitis to whatever cause, due to whatever cause, may cause a bleed, acute abdomen in early pregnancy. Acute abdominal pregnancy may be due to labor pains, if preterm or term, placental abruption, especially if concealed, uterine rupture prior to uterine due to previous scars, appendicitis. The site of the appendix is higher up than in non-pregnant women, and its size differs according to the gestational age. Acute pyelonephritis with fevers and rigors and with characteristic loin pain radiating to the pubic region, cystitis and chorioamnionitis. Watery vaginal discharge in pregnancy may be due to ruptured fetal membranes. The amniotic fluid here has characteristic odor and a positive burning test, and with litrazine paper, and it is alkaline, not acidic as the urine. Amnionitis, vaginitis, or cervicitis, and it may be urine, which is characteristic odor and with its characteristic constituents with lab examination. Convulsions in pregnancy may be due to epilepsy with a history with no hypertension and no proteinuria, preeclampsia eclampsia syndrome with that starts after 20th week of gestation. There is hypertension and with or without proteinuria. It may be due to tetanus infection with tetanus organism, or it may be due to hypocalcemia that may cause peripheral tetanic movements. It may be due to tetany, as in parathyroid removal accidentally with thyroidectomy, meningitis and encephalitis with arching and history of infection and positive CSF culture, strychnine poisoning, which is rare nowadays. Johnson pregnancy may be due to intrahepatic cholestasis of pregnancy, acute fatty liver with pregnancy, HELP syndrome with increased blood pressure and protein in urine, biliary obstruction accidentally due to gallstones, viral hepatitis, acute viral hepatitis with increased enzymes, and may be due to hemolytic anemias. Thank you very much. I wish these slides help may help you in the bedside diagnosis and clinical diagnosis in obstetric cases.